hope in the frontline setting, most of the studies have focused on aromatase inhibitors in the front line, but I guess there's some emerging data with fulvestrant even in the front line. So are we going to have a choice, you think, coming in the future?
You know, we certainly, because of Falcon, that we'll hear about more in a bit, we have approval to use fulvestrant in the first line setting, particularly in patients who are endocrine therapy naive. But the idea of what the optimal endocrine therapy is still has been a question. And actually the data from MONALEESA 3 presented at ASCO by Dennis Slayman this year is actually quite intriguing, because that design allowed patients in the first or second line setting to be randomized to fulvestrant and placebo, or fulvestrant and ribociclib. And the randomization was 2-to-1, as we've seen before. And the trial is fairly large. There were 726 patients randomized. And what they saw actually was quite interesting. You know, if you line up all those studies on a table, all the hazard ratios are the same. And it's the same in this trial population. Of course, there's a big benefit. We already knew that that was the case in the second line setting. But I think what's intriguing about this study is the hazard ratio in the first line setting is also identical. The trial wasn't designed to say whether or not it's better to give a CDK4/6 inhibitor or not specifically in the first line setting, because both groups were included, but definitely those patients did a lot better who received a CDK4/6 inhibitor, again with these hazard ratios of 0.56 around, which we've seen across all of the trials. So I think that you could give fulvestrant, and of course, I've already done that in clinical practice, but you know, somebody who has polymyalgia rheumatica and you know can't possibly take an aromatase inhibitor, I've used fulvestrant and a CDK4/6 inhibitor in a patient with de novo metastatic breast cancer, premenopausal, with extensive liver metastases, and she's been on therapy for 2.5 years, and you know, it's CR. So definitely, this is a therapy that can be considered, and I think the data from this most recent MONALEESA trial will help to encourage that. And then we'll see more data with just fulvestrant with or without a CDK4/6 inhibitor versus an AI in a Europeans trial. Fulvestrant versus AI, both arms with CDK4/6 inhibitor. Maybe that trial will actually help us to answer the question of which the optimal therapy is.
You know, you brought up a really interesting point about the choice between fulvestrant and AI, because I think we all feel like fulvestrant's probably the best drug in terms of you know, frontline therapy, but the studies weren't designed like this. What are you doing in your patients who've had 5 years of adjuvant AI and come in a year or 2 or 3 later with a recurrence? Are you testing for ESR1 mutations to choose the endocrine partner? This is coming up in the clinic now, because a lot of these patients will have ESR mutations that would predict for a better outcome with fulvestrant.
You know, it's interesting, the trials that defined first and second line used a 1-year interval from having completed an AI, but the Europeans have recently looked at the data to make a more objective definition of when does your phenotype look more like endocrine resistant versus sensitive? And they looked at all the data and where the cut points were before starting first-line hormonal therapy, and they came up with a 2-year cut point as defining sense. So I tend to use that if I'm going to use aromatase inhibitors first line. I'm going to expect at least a 2-year. But to be honest with you, I feel like you do. I think anybody who's progressed on, say, 5 years of an AI, now that we have the data from both monotherapy as well as a hint from CDK, that I would prefer to go with fulvestrant. And yet we all know that ESR mutations now, as more data comes through, probably predicts for some degree of resistance to AI and sensitivity to fulvestrant. It may not be 1-to-1, and each mutation is different. It's very complicated, but I agree with the general sentiment that fulvestrant is moving into its place of first line.
That women are getting an injection every single month, and they have to coordinate it with their travel, and it's 2 injections. So they're still going to, I mean, there's always going to be a role for AIs, and I do tend to, you know, more than 2 years out, I tend to retest with an AI. And also the idea is that if you save fulvestrant, you can combine it with another agent. There are all, you know, lots of trials going on with fulvestrant and a variety of agents, and we're going to see a lot of information about the PI3 kinase inhibitors combined with fulvestrant. So, you know, order and what to do is going to become increasingly complex, but a wealth of riches.
And the NCCN guidelines support fulvestrant and a CDK4/6 inhibitor as a frontline option. right?
Yeah.
That's
Yeah.
right. So that's good because that's very, very important, obviously, for the practicality of being able to access it. When you want to. So we're really. I'd like to just hear from Debu. Is there any role for fulvestrant monotherapy in patients?
Well, I do think there may be a minor role for endocrine monotherapy. I think in patients who have significant comorbidities or patients who are just not able to travel for the frequent blood checks, personal preferences may come into play, that it would be reasonable to start with endocrine therapy. We don't have many predictors of who can do well. The Monarch study for first line did identify a subgroup of patients that were disease-free for more than 3 years and found that they had an excellent outcome either way. The event rate was low. But really, apart from that, I don't think that we can upfront identify someone. There are some studies planned for low-risk patients where they will start with a hormone therapy versus both together and then have a CDK added to the monotherapy group, and they are going to compare those outcomes. So we may get some more information on that later.
I have to say the abemaciclib, that analysis, the subset analysis, I haven't put a lot of stock into it because first they didn't reach the endpoint in most of the sort of displays from, when you look at the confidence intervals, it wasn't reached on the upper end, and it just was way too early to understand that those people didn't benefit. And we did an analysis in Paloma 2, and when we did the last sort of PFS assessment, and there was no difference. We looked at all sorts of different disease-free intervals. There was no difference in benefit. And I think, sometimes I wonder, that if you take the patients who have the most endocrine sensitive disease, if those are the patients who are going to maybe benefit even more, and stay on therapy for a long, long time. Whole another issue talking about expense, but I think I don't know that that's really an indicator right now to decide on treatment.
Yeah,
I would agree. The largest follow-up we have is with the Paloma studies, and those forest plots look identical for patients regardless of that. So I think
no clinical predictive subsets, to
no
say,
clinical predictive subset.
Yeah, every subset benefited, But are there any predictive markers at all emerging? Hope in tissue, blood?
I think that there are predictive markers that are intriguing, but they aren't perfect. So one study I thought was quite interesting was an analysis of Paloma 2 that Rich Finn presented at San Antonio. And we had looked at many different markers and not shown anything that predicted, just as we have for all these other targeted agents. But what was interesting, looking at intrinsic subtyping, the patients with luminal A and B disease, of course, benefited a lot. There was a small number of patients who had the bad intrinsic subtypes, basal, normal-like, et cetera, and they just did very poorly. They have upfront endocrine-resistant disease. So it suggests that, really, again, the endocrine sensitivity is our best predictor. There have been a number of different studies that have been interesting recently. I think one that's intriguing is an abstract presented by Nick Turner at ASCO this year, looking at in Paloma 3, the second-line study with fulvestrant and palbociclib, looking at cell-free DNA, as well as archival tumor tissue, and showing something that we really haven't seen before, which is that RB mutations emerged at the end of treatment, even though it's extremely uncommon up front. I mean, I've seen a couple of patients with RB mutations, I'm sure we all have, who had upfront resistance to CDK4/6 inhibitors, but it's not something we would look for because it's so uncommon. But what they saw was that a small number of patients who didn't have the mutation in the beginning had it at the end. I think it's encouraging for us that it's under 5%. It was about 4.8%. But we're always going to see the emergence of resistance under the pressure of treatment. How rapidly resistance develops is important to us. So seeing that this is in a small number of patients is really important. There's also been a number of hypotheses that certain changes in cyclins will impact sensitivity to CDK4/6 inhibitors. And Fabrice Andre presented data at AACR looking at patients who were treated on MONALEESA-2 and suggested that potentially cyclin E1 might make a difference in terms of upfront resistance, that if you had an alteration in cyclin E1, which was kind of interesting. But regardless of baseline factors, similar to other studies, the sort of standard things we look at, like Ki-67, a doctor might say, oh, your tumor is very highly proliferative, I should give you chemotherapy. those patients still benefited from the CDK4/6 inhibitor. And then the other thing I've noticed is that people worry about CCND1 or cyclin D1 gene expression levels. Again, similar to Paloma-1, no difference at all in this really detailed analysis. Cyclin E alterations are, again, uncommon and it's not definitive. So that study also concluded that hormone receptor status and levels, sensitivity to hormone therapy, is really the key determinant in terms of sensitivity to CDK4/6 inhibitors.